Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we're going to be discussing all things vascular access, and there's no better guest to discuss that topic than the Vascular guy. Now, this guy does have a name, but it's part of his brand to just keep it as the Vascular guy, so I'll be referring to him as that throughout the show. I discovered him on TikTok, and I love his stuff. He's also on Instagram, YouTube, all over. He was an emergency department nurse who then went on to specialize in vascular access. He works for a vascular access team, and he's just been putting out a plethora of amazing information on his various social media venues. So you should totally check him out if you haven't already, but we have some amazing tips in this interview on things like ultrasound-guided IV placement and then central lines, and I think you're going to love it. Now, before we jump into that, very quickly, I just want to mention the Resus Leadership Academy. That is our virtual resuscitation fellowship for ED docs, internal medicine folks, hospitalists, etc. It allows you to do, in essence, a resuscitation fellowship, just like the ones we have run in person in hospitals, but in the comfort of your own home without having to quit your job, because you'll be able to do all of the lectures, the learning, the stuff that goes into the didactics offline. You'll be having meetings with a host of amazing professors in resuscitation, some of the best names in the business. And then you'll have a monthly hangout with me where we'll talk about cases and we'll go through things in a group in a very shadow boxing type format. And you'll be able to ask questions about anything that comes to mind throughout the course of the fellowship. And by the end, you will indeed be the leader in resuscitation in whichever department you are working in. So if you're interested in that, if that sounds enticing, if you'd like to do a Resus fellowship, if you'd like to up your skills to the level of a true master in things resuscitation and acute critical care, then just come to resusleadershipacademy.com. That address again is resusleadershipacademy, all one word, .com. All right, let's get into the interview with the Vascular guy. Who are you and what do you do?
I am the Vascular guy, interventional vascular access. Basically, I help to provide access to your veins and to your circulatory system so we can get you medications.
And your background is you came from nursing and then became a vascular access team member. Is that right?
That's right.
All right. And where should people know you from? I'll tell people afterwards where I know you from, but where is the place you feel most proud of that you're out there?
Oh boy, probably TikTok, because I'm able to hit the younger generation of clinicians at scale better out there. And they're going to be the ones to take over our skills and our jobs. So I'm really proud that it's able to inspire them to care about what we're doing.
That's where I follow you, is on TikTok. I love your stuff. I'm so happy when one pops up in the algorithm. Though I'm a little leery of TikTok in general. And when I was preparing for this interview, I saw you're actually on YouTube. If I was just following you on YouTube, would I see everything I saw on TikTok?
No, you'll actually see it. Each platform that I post on, you'll see something different. So on YouTube, you'll see a more full procedure playlist. It's the most comprehensive content you'll see. Not very clickbaity, not very virally. And I'm more focused on making sure that there's a complete content of information in YouTube as much as possible. And then TikTok and Instagram is where I game the algorithm to gain reach.
The first topic I want to hit is ultrasound-guided peripheral IVs. It's a huge topic for emergency medicine. The bane of our existence is hearing, oh, I tried on this guy 4 or 5 times. Doc, could you go put that in? And for the residents, this is a regular piece of their day on shift. And I know you have so many great tips. Why don't we start off with first, what length of catheter do you consider the minimum for an ultrasound-guided IV?
Can we get pedantic or you want me
please,
to
no,
dumb it
pedantic
down?
is where we go, man. So how much do you want in the vessel to know that when they move their arm, it's not going to pop out?
So that depends on where
time.
That's a great question. It depends on where in the patient. So everything I do is critically thought out and decided, customize the care for the patient. And that's where I love where my specialty is. I don't have to just think, okay, ER, everyone gets a 2.1 centimeter 20 gauge. I don't care if you're here for foot pain. I can actually think critically for what's best for the patient. So what length? Your catheters are probably too short. 2.1, in my opinion, even in an emergency situation, is unnecessarily short. There is just from watching the skin move. Just take your patient's skin and go back and forth. Look at how many centimeters it's moving. You can have I think what we had in the ER was a standard of 2.1 centimeters. If the patient's skin is moving 4 centimeters, that 2.1 is going to come out. It's not going to come out of the skin. That's what people don't realize. It will stay anchored to the skin. You can glue it, staple it, bake it, whatever you want on the skin, and it will never move from the skin. And so you will never see it infiltrate. However, that skin will pull that catheter away from the vein and it'll piston it out. And I have videos of me taking the hub that's anchored at the insertion side of the skin and moving the skin left and right. And you can see that catheter sliding back and forth about 2 centimeters inside the vein. I think you guys should really advocate for at least a 3 to 4 centimeter long catheter, or longer catheters at least, because these 2.1 will not sustain with our patient's skin moving more than 3 centimeters. So be mindful of that. Your anchoring, although you did a beautiful job, will not hold it inside of the vein. There's nothing to anchor the catheter in the vein. So it will piston out if you're not careful. So advocate for longer needles. If they have an upper arm insertion, most likely we're going in deeper. Most likely their skin is more loose. Even for me, this is a lot more loose in my upper arm than it is in my forearm, than it is my hand. If I see and feel that the skin is very loose from either weight loss or a patient's emaciated, usually weight loss and even obesity comes into play because their skin is so stretched, then I will add a few centimeters required. So let's say a 2 centimeter depth, usually for that brachial or basilic, and I need to tap that vein to have enough in there. I'll probably use a minimum of a 5 or 6.4 centimeter catheter because I want at least 2 to 3 for emergency. If I want that to last for a couple days, I will put in a 10 to 20 centimeter MST catheter.
All right, let's talk about what this MST catheter is. Now, MST stands for Modified Seldinger Technique. Now, I'm not sure exactly which model the Vascular guy is using, but I think what he's referring to is the same thing we would refer to as a short midline. Now, I've done 2 episodes on this with Rory Spiegel. The two of us published a paper on midlines in emergency medicine, and we had 2 strategies. We had long midlines we used for patients going to the ICU to replace central lines, and then we had short midlines. And the short midlines were for, in lieu of using long peripheral catheters, for ultrasound-guided IV placement. And this was a revolution for our departments because these were just so much better. And they allowed you to place in deeper vessels. They had much better longevity because they didn't pull out because they were long enough. So these were 10 centimeter Seldinger technique, not modified Seldinger technique. And the ones we were using, and I don't take money from this company, it was the Bard PowerGlide ST, and ST stands for Seldinger technique. And what it was is it's a thin bore needle that you could just see very well on ultrasound. Get that into the vessel. You start seeing blood, coming out of the back of the hub. You put a wire in, you take the needle out, and then it had a catheter with an integrated dilator that would go without making a nick over the wire. You'd put that all the way into its hub, 10 centimeters in. Then you take the wire out, and then you take out the internal dilator of that catheter. Now you're left with a catheter sitting there, 10 centimeters in the vessel, and it is a material that's made for extended dwell time. So you can leave this in, 28 to 30 days. I don't remember whether it was 28 or 30, but the point is it could stay in the patient's entire hospitalization, very unlikely to not be able to be used for their entire time. A lot of the time you could draw blood back from it. It was the delight all around, so much better than these ultrasound-guided catheter over the needle long IVs that would always blow at the worst possible moment. And so that is what we would use at the same space that the Vascular guy is talking about, these MST catheters. And my guess is we're kind of talking about similar things, is my guess. All right, if that doesn't make sense, put it in the comments and I will elaborate further, and check out those midline episodes. All right, do you prefer transverse or long for your peripheral IV insertions?
So for my peripherals, I prefer transverse because I like having both X and Y axis of control and visualization, especially because the veins are smaller. I have a smaller margin of error. So for those veins, I prefer definitely the transverse.
Love it. All right, what angle of insertion Are you shallow? Are you deep? Is it totally variable depending on the vein? Is it you start off super steep and then you shallow out? What is your move on this?
That's a great question. It's variable. Of course, it has to. There are times when, let's say in an emergency, I'm helping out at the ER. They're like, hey, this guy needs pressures. They're panicking. We just need blood in them. We just need some kind of 20 gauge in there. Great. So I get them a 20 gauge and then I don't do a full scan because I see a good vein, but I don't see past it. I see a good vein. I know where I'm going to hit. I go in and then the vein goes more shallow. I'm like, crap. So then I have to shallow out. And so there's different variations. The angle of insertion is dependent on every patient. So I usually do a full scan because most of my lines are long-term based and the goal is to keep them in for as long as possible. And so I fully assess, see where the vein's moving, how it's moving, and then I determine the angle of insertion. There's a computational study done by two friends of mine, Peter Carr and Andrew Ballmer. They have found that the angle of insertion is exponentially inversely correlated to the dwell time of that catheter. Mm-hmm. But the higher that we insert, the less likely it's going to last. It's gonna fail sooner. And we still don't know the etiology. We just know the correlation. And so there's a lot of research being done on that with angle of insertion. So your needle length matters. You need to read, even if your catheter is 10 centimeters, if your needle's 5 centimeters, you still have to go at a steep angle and you're not helping out with that dwell time.
I love that. That's fantastic. And you and I could both guess some reasons why. I bet some part of it is the actual users who are choosing shallower angles in general, I find are far more experienced and I think that's going to be a part. But no, that's fascinating. I'm curious to see where that goes when they actually have caught explanations. All right. Some tips for needle tip visualization during transverse ultrasound use.
The most common mistake that I see when I'm out training, consulting, is that they are so static with their probe hand. The needle, you can adjust it, but it's not, it's not a variable you want to change too much. Because if you compromise access for visualization with the needle, that doesn't make sense. We need the needle to hit the vein. The needle has a fixed vector that we need to go at. So the only thing that we can change is our probe hand. And so what people don't realize is that probe beam has a reflective behavior and the technology is based on the reflectiveness of that beam. So let's say I like to use lasers a lot because it's the most easily visual to conceptualize. When a laser hits a mirror, it bounces. It goes somewhere depending on the angle. It either goes away from the laser pointer or it points back, reflects back to the laser. The ultrasound beam behaves the same way. It's a beam of sound, of energy that's going down to a surface and then reflects back. And so we need the angle of the beam of the probe to match the needle if we want to see the needle, match the vein if we want to see the vein, or whatever artery or whatever nerve bundle that we want to hit. Whatever object we're trying to visualize, we have to rotate or fan the probe to the angle to match that object. That's the most neutral academic way I could say. The easiest way to understand this is make the probe perpendicular 90 degrees to the needle and you'll see it better. And of course, with that, you just place the image, so you have to slide it to make sure you find your needle tip properly. But that is the most common mistake that I see people doing and missing when they're ultrasound needling.
Yeah, I love how you just took all that scientific explanation and then boiled it down to what people actually are going to be able to use at the bedside. And that's key. That's it. Perpendicular to the needle, you're going to have better visualization of the tip. You might lose some visualization of the vein. That's okay, because the needle tip's what you're going to be following. Now, are you a fanner or a slider?
To do both. If I only fan, then my image is reporting back to me a displaced location. What does that mean? So at a fixed point, the fulcrum point, which is at the skin, if I only fan, then I'm visualizing a different part of the vein that I originally was looking at when it was perpendicular to the vein. And so I need to point, visualize the needle, and then fan it to my target vein. And so I have to follow it down to where I'm hitting the vein.
If you had to pick one at-home or in a sim lab technique for people to develop the skills and the bimanual dexterity to be able to do both probe manipulations and needle manipulations, what do you recommend? Is it a phantom? Is it something that people can make on their own? What is the best training for this?
One, and this is gonna lose my opportunities with simulation companies, but hands down, until they can figure this out, hands down, chicken breast or turkey breast has been the most realistic simulation. Now, I think I lent my Phantom or my simulator. I don't think it's called a Phantom. It's something else. It's a simulator I bought for $500. I don't even care where it is anymore, because if I want some real learning from people that I'm doing workshops at the conferences, at this hospital, that hospital I'm consulting, I will go buy a few chicken breasts and drive balloons through it, like long balloons through it. With this knitting needle, it won't pop, surprisingly. And now I can change vectors. I can curve it. I can make it cross two different veins. I can change the variations of the simulation for the person that I'm teaching. And even for myself, if I'm practicing deep or shallow, very shallow insertions, I personally can change it, the simulation, for $10, 15, including the balloons, to get the most optimal tactile feedback you're ever going to get with any simulation.
All right. So when do you recommend spinning the bevel 180 degrees? Are you doing this at initial insertion? Are you actually getting into the vessel and then spinning? Are you spinning all the time now? You've done a bunch of videos showing back wall puncture just seems to be markedly less with the bevel spin. Tell me about this.
Okay, let's do a deep dive into this. Let's first talk about why it was even a thing. Why did I even post it? Why did I even contemplate this? Someone commented, hey, inverting the needle will help to reduce that snag you keep talking about. BS. I didn't buy it. I was like, that's crap. That's so stupid. That's dangerous. It'll cause torque to the veins. Like, it might be painful. And that demo, my viral video, at that demo was when I was trying to prove that it was wrong, that you shouldn't do this. And when I saw it not scraping, not snagging on a latex surface, which is...
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Has more friction than a venous surface. Veins have glycocouch protein, has that nice smooth layer and that gel layer to help smoothen things. Even without that, with a high friction surface, it was able to glide better. And my reaction to that video was a real reaction like, oh crap, I was wrong. So I showed it because I wanted to show people that even my initial perceptions of something that someone told me I needed to see for myself, and it completely changed my perspective of someone's opinion. And so I had to actually see it for myself. So when do I do that? I do that after I'm in the vein. I don't do it before I'm in the vein. The reason being, I find that it's easier to pierce the vein or the artery, the vessel, when the bevel, the sharp side of the bevel is pointing towards the object. So how I verbalize it now is if I want to puncture, I will face that sharp end to where I want to puncture and that flat surface to where I don't want to puncture. I'm usually in the vein when I'm using that technique, and it's mostly because I want more of that needle in there, more vein purchase with that needle, so that when I'm letting it go to manipulate the guide wire, the dilator, I don't have to worry about it slipping out. And so it's a technique that I've used to get more vein purchase while reducing endothelial injury as much as possible. Now, caveat, it is not possible for every insertion. So if you have enough room to stay center with that needle tip, and you can stay center and you don't have to invert, that's the best way to go. Less manipulation is always better. However, there are going to be situations where you don't have enough skin or space left. And the vein is either going up more superficial, and we need to get more of that needle in without causing damage, without puncturing through. And so I use that technique then. It's not very common that I use that technique, but it's a tool that I have to give the patient the best outcome long term.
Any peripheral securement recommendations? We get these sweaty patients in the ED. They're all, and these IVs just fall out left and right. Is there anything you do differently than anyone else does?
That's a tough one. Diaphoresis, you're SOL in all fronts. Right now, there is no ultimate alternative. I think right now there is cyanoacrylate glue. There's a product out there that's fantastic. It's basically super glue on the skin. It's great for PIVs. They recommend that you use it for the catheter, the insertion site, and the wings. And now you have a chemical adhesive securing the device down. However, in my experience, diaphoresis just ruins all of it. It's very difficult. I would say you probably need some kind of physical wrap, like a Coban or something to put pressure and hold that in place if the diaphoresis truly is a problem. However, be careful with that, because now there's increased risk for clotting because we've tightened that wrap around. So that recommendation is really there's no other solution. We can't get a centralized reason, or for some reason, we can't get an IO. We've got this one PIV. He or she is sweating so much. This is all we've got. I recommend do whatever you can to keep that in there. Dislodgement is the number one priority at any point in the life of the catheter. Without that catheter in the vein, there's no point in using it. You have to keep it in the vein.
No doubt. You just brought up another question that came to mind, which is, I'm watching a nurse place an IV. And look, our nurses are friggin' amazing at IVs, but every so often you'll get a nurse who's not as skilled, and he will be placing the line and he'll enter the vein and there'll be no flash. And then I'll watch him pull it back, pull it back, pull it back, pull it back. And then finally there's this blip of flash and then advances the catheter. Now, in my mind, because I don't know where the valve sits for that catheter tip, that's a line I can't trust. That's the line that's going to blow because he's backwalled the vessel. Should that just be pulled at that point, or do you let it stay and let it dwell a little bit and then just don't trust it? Because I just immediately say in my mind, I'm not using that for anything important. Even if it looks like they pulled back blood from it and everything. I hate it. So what's your stance on that?
That's the key point. Anything important. So if you're running medications that is a vesicant, let's say pressures in the forearm or wherever they placed it, if it's an irritant, that medication, like even ceftriaxone, my director called it water. It's like water. It's not supposed to do anything. I've seen that medication clot a 28-year-old athlete female with their midlines in both arms. So even something as innocuous as ceftriaxone could irritate and cause a thrombosis cascade. If it's just hydration, we infuse hydration subcutaneously anyways. So if it gets infiltrated, they got their fluids in. It'll absorb osmotically in other places through the collateral flow, collateral veins, vessels. But yes, I would not trust it to last long. In fact, if they're coating, and you saw that, I think it's worth starting the pressors, find the second site quickly. Just know that it's going to infiltrate and extravasate that vesicant. But it's critical thinking. You still have to apply the risk to benefit analysis. It's in there. We flushed it. It's not swelling. There is an opportunity where that clinician may not have punctured through to the other side of the back wall. So it's still a viable temporarily, but it's viable. There will be thrombosis at that site. There will be a cascade developing. However, for the emergency, they need it right now. Let's get that medication in while we're looking for another vein.
Is there anything else we should talk about on peripheral IVs before we move to a more contentious topic?
The hand, in my opinion, and I'm going to prove it someday if someone can fund the study, hand is probably the worst place for longevity. I understand it's the easiest to access. And again, in the ER, there's a lot of rules that we break and a lot of chaos and speed that we need to work in. So outside of those situations, if you want your IV to last, the hand will be the worst place because of high flexion. The zone insertion method, although it was written for the upper arm, it still applies to the lower extremity, the distal part of the arm. So you want to insert in a place where there's no flexion or least amount of flexion to make sure that dressing stays intact and that catheter stays intact. That would be one thing I think a lot of people miss. They put in the AC, great. The CTA, fine, they need that. Or if there's policy in place, you're going to get in trouble. I can't control that. However, if you're looking for longevity, the forearm is going to be the place to put it. And there's bifurcation and conjoining junctions that you can take advantage of to dilute the medication. And before we go into the upper arm, the reason why I favor the forearm sometimes, actually a lot of times, is because the hemodilution factor is more prevalent in the forearm than you are in the upper arm. So you're actually going to get hemodilution depending on the collateral flow of the veins, and you're just choking up that entire bacillus. You're causing hemostasis, endothelial injury. And so the likelihood of that midline failing is a lot higher than with the PI and the forearm. So there's a trick to that. I have whole videos on that. It's a whole explanation. But if you can understand that piece, you will actually get those forearm IVs to last. Check this out. 14 days of vancomycin in the forearm until end of treatment.
Lovely.
That was the longest recorded at this one hospital during their study. That's mind-blowing.
It's fantastic. Now, at this point in the interview, I introduced the topic of long midlines. And I thought it was going to be contentious because the vascular guy in his various posts has seemingly knocked midlines. And I thought we'd have a rousing debate. And the vascular guy just would not rise to the bait. He was super fair. He gave some of the potential issues with them and the inability to really know the relative size of the catheter in the vessel you actually wind up in is definitely one of them. He mentioned an increased risk when they're past the axillary crease, moving towards axillary vein and even subclavian. We will not let our midline sit there. I could not agree with the vascular guy more. That is a very dangerous area. We would always make sure our midlines terminated before the axillary crease so that they remained in the arm. I think you could get into a lot of trouble there, so we agreed on that. We agreed the larger, the higher the DVT risk. But there's been an RCT, I think a couple RCTs now, and there's been a systematic review of the extent literature, and I'll put those in the show notes. And both of them agree that the risks compared to PICCs are not significantly greater. And that's what I really cared about, because that's really the comparison here, is PICC versus midline, because the vascular guy is placing PICCs primarily. He's part of a vascular access team. And what we came to at the end of this debate, and I cut it out because it's probably not interesting. We're just in fierce agreement. Things are not as interesting. But what we came up with is the idea that I think midlines are easier to place. And I think it's fine. He thinks it's fine for a ED team, intensivist team to place midlines, to get the job done, to start pressors. And then if you think they're going to be in for an extended period of time, it's not a bad idea to consider calling the vascular access team and having them place a PICC. PICCs are a pain in the butt to place in the middle of your shift if you're not part of the vascular access team. You could do them, and if you want to send a patient out with them, you certainly could do them as just a regular doc. But midlines are a lot easier. Midlines will get the job done. Midlines, depending on your anticipated hospitalization, may be all you need. You might not need a PICC. You might have a patient, okay, I think they're going to be out of here in a week. You might never want to go down the PICC route. But the point is they both have their place. You have to understand the risks and benefits of both. Midlines are probably safe. Use the smallest one you could get away with. And we'll leave it there. All right, let's go to central lines. You have had so many beautiful videos of, and IJ is the most common line in both the emergency department and in the critical care units, of IJs that are placed such that the lumens are sitting on the chest rather than up in the neck. So how do you make that happen, and why should people be doing this?
It's great. First of all, I got to give my props to Dr. Jack Liddell. He's been my mentor for a few years while I'm in the space. Dr. Pittaruti, Matt Ostroff, Joe Bunch, these are guys that are pioneering these central line procedures. Dr. Liddell's main focus is infection control. When we put it in, if we put it in right the first time, we can reduce the significance of that infection risk significantly. The problem with the catheter tail pointing out at the neck is the weight of that catheter and the weight of the tubing. The dialysis tubings are hard itself is going to utilize gravity to pull that dressing out. And in my opinion, I believe there's actually studies to prove this too. The dressing disruption is one of the main causes of central line bloodstream infections. Another is actively injecting microbes and contaminants into the body with our flushing and our mishandling of the catheter are the two main reasons why the patient gets infected. I don't believe it's the catheter type. This plastic cannot produce bacteria. There is a school of thought there that believes that fibrin sheets and development of fibrin contaminants there, like the bacterial load, the biofilm developing. But I've also seen PICC lines completely coated in biofilm, in fiber sheets, and they never had a bloodstream infection. They were quite healthy, and we ended our treatment because they weren't cultured. So I don't think it's the catheter. I don't think it's the locate. That vein in the neck does not harbor more bacteria inside that vein. The femoral vein in the inguinal crease does not harbor more bacteria. It does not produce more bacteria. It's clinician dependent. It's how we put it in that determines whether that infection increases or not. So I want to set up the nurses to succeed in keeping that line clean. And if I put it in the first time, the nurses are set up to fail. And I need to lead them into successfully taking care of that line.
All right. So how do you make it happen so that the tail is not running up towards the head?
So from the clavicle, the higher up you go, the more up the neck you go, the more difficult it will be to turn that catheter down. And so with ultrasound guidance, I can navigate that needle safely at lower part of the neck. Basically, my needle's touching that clavicle, that it's resting up against that outside skin of the clavicle, trying to puncture that vein. Once I get lower in the neck, I can now easily turn that tail down to the chest. That gravity is not working against that dressing.
What if they're staying towards the lower part of the neck, not quite as low as you're doing, and they do a loop? Is that going to be a problem to have a loop there? Yours are beautiful. There's no real loop there. But if they had to put a small bend to send those tails down, is that going to lose significantly what you're...
Fantastic question. That is dependent on the manufacturer of the catheter. So speak with them and ask them about that. What I know is with Teleflex and Bard specifically, just from my experience, those two brands have the ability to turn it past 90 degrees and not lose flow rate. And I believe it's because of the makeup and the thickness of the catheters that they're allowed to do this. So they have tested it. The reps should know how much of an angle you can angle it. The catheters that I use, I know that I have more give with that. And so I can get away with that. Now, with dialysis, there is an issue with it. The more you bend it, the more you turn harder, a sharper turn, the more you're going to interfere with flow rate. So instead of turning it all the way to the chest, turn it to the shoulder. Again, the point is, regardless, I even had it pointed back around the neck behind the scapula, where it still rested beautifully. It's still curved beautifully. And the patient was alert enough that they weren't going to cause bed sores. They weren't going to pull it out by accident. And the dressing was able to stay on, and the nurses were able to have their high flow rate without interruption.
I'm still from a school where we're sewing in our lines, and I think I'm pretty quick. I've done so many central lines. I still hate it because it adds a significant portion to the procedure. It's a needle stick risk. They've stopped giving me straight needles. Now it's all instrument tie, which takes even longer. What is the 2024? What would be your recommendations for primary securement of central lines?
100%. This has been proven in so many different studies with so many different variables. Sutureless securement is the way to go. There are 3 forms of sutureless securement. There's adhesive sutureless securement. There is subcutaneous, and then there's chemical, so cyanoacrylate. But those are the 3 ways that I know of that can help to anchor that catheter down without disruption or without dislodgement during the dressing change. My favorite is going to be the sutureless securement because of what I've seen it do in weird situations. Super diaphoretic, doesn't matter. There's no adhesive. There's no chemical to rub off the skin. It's literally anchored under the skin. and holds that catheter for the entire duration. Even my tunneled catheters use that device. And it depends on when, but most cases, I don't use a Dacron cuff tunneled catheter. I prefer the non-Dacron because it's less trauma to remove. And so that securement, that sutureless securement, that subcutaneous device can help keep it in there for the entire duration, years if they need. And so I lean towards that. I have used cyanoacrylate and I have used the adhesive, and I will continue to use those as appropriate for that patient.
Now, is SecureCaf have a monopoly on this, or are there other devices besides that you've tried?
So far, there's nobody that has a subcutaneous based securement mechanism that I know of. I haven't seen anything like it. It looks gruesome, but when I looked at it with the microscope camera and the insertion, and I was worried that it would look sharp, like under the camera. Right. And I was doing it live. I was like, oh, I hope it's nice and round. And so when I poked it through and saw it through the camera, I was like, oh, that is surprisingly very round. So it looks sharp, but it's not going to cut anything. In fact, I've seen patients pull it out completely and the hole is still there without an incision or incised cut. Yeah.
Do you use a secondary securement in addition to that if you're using the subcutaneous, or that's just it?
It actually gets in the way. If I use a secondary securement device, not only does it waste my time, but it gets in the way of real estate, literal physical square inch of my dressing technique or my strategy. So I don't need to, not that one.
All right. What are these subcutaneous securement devices? I'll put a video in the show notes. What these are is they go into the actual hole that your catheter is sitting in, and they lock with metal around the catheter into the subcutaneous space. And they seem gruesome, and yet they're not. You know, he spoke about looking at them under a microscopic camera and them actually being nice and rounded. But these things are brilliant. No suturing, no adhesives to wear off. They are durable. They are clean. They are easily dressed. They're a delight. I don't take money from these companies. Vascular Guy's not taking money from this company, but we both love them. And if you can convince your hospital that, avoiding needle sticks, which are a huge, no, and, should be a never event, and avoiding the time makes these worthwhile to purchase. And, if they could prevent central line infections by keeping the catheter from knocking out the dressing and therefore exposing the site to increased infection, then, it's going to pay for itself. These, I really like them. I think this is the wave of the future. I'd love one of the big organizations to say that hospitals should be using these because it's just so much safer for the provider. So check it out. Again, no conflict of interest. I just think they're great. So I guess the next question, Vascular Guy, is what is the worst thing you've seen around central lines in the ED and ICU?
The problem in ER right now is contamination issues. We're not AMTT, we're not sterile. I've seen an ER doc put in a fem line, like raw dogging the probe, putting in that fem line. I'm like, we got to collect up like ASAP. We got to put something else in. And they standardize that practice. It wasn't even just at one moment. They do it all the time. And nurses, they do these hacks, but they're also contaminating.
Let me give you a little insight into the femoral raw dogging. I actually prefer that because the worst situation would be for an EDOC to tell me they did a sterile line, but they didn't do real sterile line, right? Because they're a little bit more relaxed on the definition of sterility. So when they put in that shitty raw dog femoral, that's coming out within 24 hours. And I don't even have to pretend. The worst scenario is when they write in their note, full sterile central line placed, and I wasn't there to watch it. That's the travesty. Because now I have to really make a judgment call based on the individual doc of does he actually know what he's talking about or not. So I love when they put in the garbage femorals because
so you have to put it in
we'll get a pick in, we'll get that one out. Because I know, like now we can just have no doubt that is a garbage line from the sterility standpoint. But the dangerous ones are the ones they claim they did sterile.
That's the risk to benefit analysis that a lot of people don't take into account is who did it.
Yeah.
Because logistically, we have to consider that. Yeah, for sure.
Yeah, love it. All right, Vascular Guy, can't thank you enough for coming on. This has been an amazing conversation, and people have to go check out your stuff if they have not already.
Absolutely. Appreciate your time, and I'm a little starstruck. I've been listening to you when I was in my ER days, so it's really cool to loop back around and see you in person. So this is kind, man. Privilege for me.
And there you go. I hope you liked listening to that as much as I liked doing the interview. Some great tips in there. You could check out all of the Vascular Guy's stuff on the links I have in the show notes for this episode. I have the links to all his various social media venues there. Check his stuff out. I think it's great, especially for nurses. If you're a nurse listening to this and you're not checking that out, you're missing out. Because in addition to all of the things about vascular access, he discusses tips and tricks for drawing blood, for keeping hemolysis from occurring, all sorts of crucial stuff. Maybe we'll even do a second episode on that stuff because I think it's so important. All right, remember the Resus Leadership Academy. If you want to do a Resus fellowship in your own home and not have to leave your job, that's resusleadershipacademy.com, resusleadershipacademy.com. This has been Scott Weingart for the EMCrit podcast saying bye-bye.